great talk. I always learn a lot when you speak. You've covered a lot of what I needed to cover, so so hopefully I can sail through mine fairly quickly. What I thought I'd cover is more a sort of a broad approach to how we would consider anyone that we suspect of having connective tissue disease, features of some of the key connective tissue diseases, which I think Carol actually did a fantastic job of. So hopefully I can just build on and then put in the extra on our approach to diagnosing these things. I just see my internet is a little bit unstable, so I'm going to stop the video as well. So what is a connective tissue disease? Well, a connective tissue really, as everyone knows, the muscles and bone and so on. But really, when we talk about a connective tissue disease, we're not really, there are two ways of talking about it. Some people talk about a connective tissue disease as a disease such as Ehlers-Danlos or something where there's an inherent problem with the structural function of the tissues. When we as rheumatologists speak about connective tissue diseases, we speak mostly about diseases that are damaged or involved, that are connective tissues, but that are damaged or involved as by or damaged, or where the immune system is involved in causing the damage. And so from my perspective, and for this talk, we'll be talking about those connective tissue diseases and not things like Ehlers-Danlos, etc., which many people also refer to as connective tissue diseases. Just a quick reminder of where your rheumatologists are. South Africa is not exactly rolling in rheumatologists. International guidelines say we should have one for every 500,000 children, and we should probably have, we could have by that count 40 or 50 pediatric rheumatologists. As it stands, we've got 6 down in Cape Town, most of whom work part-time. Only one of us is permanently employed, and 3 in Joburg who cover both public and private service, and 1 in Durban. But we do have a number of experts, and hopefully some of them are on the call. I call them experts because they really are, who do pediatric rheumatology without having registered as a subspecialist pediatric rheumatologist. And there may be others that I'm leaving out, but I work particularly closely with, for instance, Joe Alt and George, and then Cherie, and Dr. Levy in East London, Morris. We also have 2 training across, currently has 2, and there's a training center in Johannesburg, but as far as I know, no one's currently training there. So when you talk about a connective tissue disease, it's really, it can be anywhere in the body. As you can see from this slide, connective tissue disease can involve the central nervous system, the heart, literally every part of the body. I'm not going to go through all of them. And individually, all of these things are rare, but collectively, juvenile idiopathic arthritis, SLE, juvenile dermatomyositis, and scleroderma, and nowadays also MIS-C. In addition to that, we also, of course, in the broader picture, look at the collective vasculitides as well. Those are the things that make up most of our workload, with autoinflammatory diseases increasingly becoming part of that workload. So I mentioned autoinflammatory diseases, and when our first question really is this autoimmunity or is it autoinflammation? Now, autoinflammation is a newish term. It only was coined in about 2007 after the description of a familial form of periodic fever known as Hibernian fever, and or TRAPS, and this the elucidation of the pathways of pathology in this condition led people to the concept that everything is not autoimmune, and that there can be this concept of autoinflammation. And the real difference is that perturbations that cause autoinflammation are of the innate immune system. So your first line of response, your rapidly reacting cells that are explosive, that cause fever, that cause pus, that have a predilection for skin, bone, eyes, mucosal surfaces, and so on. Whereas autoimmunity is your adaptive immune system, and so it tends to have a different evolution and is driven by a different set of cells, by B cells, T cells, and regulatory T cells and regulatory B cells for that matter. And so often the innate immune systems can be, diseases can have a very specific family history and can be inherited, but that's only true for the ones that we know are monogenic. There are other forms of autoinflammatory disease that are not as strongly inherited, but certainly have very classical features of autoinflammation rather than autoimmunity. And the treatment can be slightly different. What's wonderful about the autoinflammatory disease, which cytokine is out of whack, you can literally just find the antibody against that cytokine and can have quite targeted and very, very effective therapy for these conditions. For instance, if you take a child with neonatal onset multi-system inflammatory syndrome, which is a disease which is 100% driven by a problem with the inflammasome that causes an increase of IL-1, you can cure that patient for life, essentially by suppressing IL-1 for the rest of their lives. And we use slightly different mechanisms to control autoimmunity. And all diseases nowadays are grouped into autoinflammatory versus autoimmune, and also there's a spectrum of autoinflammation versus autoimmunity. Some things, like systemic JIA, have a lot of features of autoimmunity, but also some of autoinflammation, but also some of autoimmunity. And conditions like the other forms of JIA can have features more of autoimmunity, but may also have features of autoinflammation. And something like ankylosing spondylitis or uveitis or Behçet's or reactive arthritis, these conditions can have features of both. And Crohn's disease, for instance, can also have quite a lot of autoinflammatory features compared to autoimmune features. And so how do we go about teasing out those two clinically? It's really about the pattern of inflammation and the types of systems that are involved. And it boils down to pattern recognition, both in terms of the clinical features and the laboratory features, where there's a flavor to a thing, whether it feels like it's being driven by neutrophils and explosive inflammation, and it could be periodic in nature and very explosive, or whether it's more chronic and appears to be driven by a different mechanism with, for instance, not raised inflammatory markers, but serious evidence cutaneously of inflammation. The difficulty with many of these conditions is they present in any potential organ system. I was at a vasculitis meeting this weekend where a condition such as deficiency of ADA can classically present as a vasculitis, but can actually present as a hematological problem or as a neurological problem without actually the vasculitis being evident. So the organ systems can overlap, can change within the same disease, and it can be very difficult. So it's not clear it's not easy to think of a connective tissue disease as just a musculoskeletal type of condition. It really avoids everything, involves everything, and as a result of that, the differentials can also be extremely wide because everything from malignancies, infections, non-accidental injury, behavioral issues can have, for instance, at the vasculitis meeting this weekend, there was a slide of what was purported to be vasculitis in the forearms, which was actually psychiatric behavior of sucking of the forearms and self-harm. So here's a typical case of a child who comes in with a limp. She's walking. She's got involvement on the left side only, and there's a 5-week history. Now, for this child, the differential diagnosis most common for her would be that she's got a fracture, an injury, or non-accidental injury, that she has osteomyelitis or septic arthritis, or possibly reactive arthritis. She might have developmental dysplasia of the hip, malignancy, TB, HIV, or an inflammatory condition such as JIA. And with the clues that we use to try and unravel which of these is involved, are really looking for morning stiffness. If you look to the bottom right, morning stiffness is a feature of an early morning stiffness, and gelling are features of inflammatory disease. Night pain can be a sign of inflammation, but also we always worry about malignancy with night pain. And if the history is incompatible or there are other risk factors we think of in accidental injury, if they to thrive contact, we always consider that. Lethal sepsis, that can also point to malignancies. So when we examine a child, the first thing about a child who presents with a joint problem or a connective tissue problem that makes you think that there might be multisystemic involvement is to examine all of the joints when they have arthritis. So it's not good enough to look, if they say they've got knee pain, to look at the knee. You've always got to examine all the joints, and the PGALS examination system allows you to do that in a very quick and efficient way without having to necessarily examine each joint in detail. But once you find a joint that has got inflammation, you are mandated to examine every joint in detail. So you confirm whether there's an infusion, limitation, or pain, and once you've got those within a single joint, you have to go and examine all the others. Then you look for other signs such as vasculitis, psoriasis, panniculitis. Those are the main things for lupus and other conditions. Psoriasis is also obvious because of psoriatic arthritis, and panniculitis is often involved in a number of conditions such as sarcoidosis or even polyarthritis nodosa or something like that. The eyes always need to be involved. Not only do we overlook very frequently dry eye symptoms in children for Sjogren's disease, but it's especially key because the JAA often affects the eye, but so do many of the autoinflammatory conditions can have profound eye disease. And in fact, we've got children now with MIS-C or a MIS-C-like pattern who have post-COVID presented with the most extraordinary eye inflammation. So the eye is kind of part of the joint examination, in my opinion. We also look at the muscle, of course, for muscle strength and so on. And we look at the ENT, especially for oral ulcers. Again, because children don't complain of oral ulcers necessarily, they don't often realize they're there, and they're not always painful. It's important to actually look for them. We also look for voice changes because these can be a strong sign of other conditions such as vagus or granulomatous with polyangiitis, or it can also be a sign of a condition called Farber's disease. And then capillaroscopy should be part of the clinical examination of every child with suspected rheumatic disease, and I'll go through that with you. Just a quick, I'm not going to go through all of the rash features that we look for on a slide like this. But I will point out the ones that are shown in picture. For instance, if you see a child with swollen fingers or dactylitis, it's important to look behind the ears for psoriasis. Psoriasis often hides behind the ears. This is just a subtle livedo reticularis of polyarthritis nodosa, and a girl who had profound airway involvement with polyarthritis nodosa. And this is the obvious Henoch-Schönlein purpura where you can see the rashes and mixed connective tissue disease or connective tissue disease look for in the eye. These are posterior synechiae, these gashes within the iris that distort the pupil. These are caused simply by scarring that is causing adhesion of the iris to other parts of the eye, and that distort the pupils, such as shown here. And you can see this irregularly. If you see a child with oligoarthritis, for instance, or a single or fewer than 4 joints involved, and you look in their eyes and you can see this band keratopathy, or you can see keratinic precipitates, or this haziness or these punctate lesions in the eye, or you see posterior synechiae, you can make a diagnosis of juvenile idiopathic arthritis instantly because these features are so typical of uveitis that we see. There were no other features. She had a swollen left knee. She had overgrowth on the affected side, which is a feature of JIA, that the involved leg becomes longer than the uninvolved leg. And indeed, when this young girl was screened for uveitis, she had that. And of course, she then had a diagnosis of juvenile idiopathic arthritis. So do we need to do an autoimmune screen, and will it help us in a case like this? So this brings me up into how do we interpret the blood tests that we use in rheumatology. So the first is a rheumatoid factor. A rheumatoid factor, the concept of an autoimmune screen is not really one that I like. It's kind of it's not such a firm concept that it's actually helpful in clinical practice. In clinical practice, what you need to do is consider the differential diagnosis based on what you have clinically, and then direct your antibody testing to that, because an RF on its own means nothing. A child with flagrant polyarthritis and a positive RS, a rheumatoid factor, means something. But a child with flagrant polyarthritis and a negative rheumatoid factor, again, that rheumatoid factor doesn't mean anything. The child still has JIA. It's just a classification tool at that point. ANA is, of course, useful in diagnosing lupus, but it's also useful as an additional clue in things like dermatomyositis, in the uveitis, or JIA, especially associated with uveitis, can be positive or usually is positive in scleroderma, for instance. So if your question is, have I got one of these diseases, and ANA is useful. If your question is could this be something autoimmune, and ANA is actually not that useful, because it can so often be falsely positive as well. A double-stranded DNA is a lot more specific for lupus, and that's nice to do. And extractable nuclear antigens are very useful once you have a clear idea of the type of disease that you're looking at within lupus. Other than that, they don't really have a role. They're really for diagnosing risks within people who already have lupus. The anchors can be quite useful if you consider a patient to have vasculitis, and of course they're positive in the anchor, positive vasculitides, and they may also be positive in Crohn's disease, and ASCAs, for instance, can help you with Crohn's disease as well. But take-home message from all of that is those investigations are only valuable if you have a clear clinical question in your mind that you need answering. If you're doing them as a screen, you're likely just to end up confused, and your patient will probably end up poorer. So the subtypes of JIA, I'm not going to go through. I hope most people are familiar with these. But just to summarize, oligoarticular disease is fewer than 4 joints, often ANA positive with uveitis. If more joints become involved after 6 months, it becomes extended polyarthritis. And then we also have polyarthritis, which is rheumatoid factor negative, polyarthritis, which is rheumatoid factor positive, psoriatic arthritis, enthesitis-related arthritis, which is the most, you can see which is the most auto-inflammatory of so far of the group that I've described. It's the juvenile version of ankylosing spondylitis, and then systemic JA, which is so auto-inflammatory that it's completely outside of the box. It's got very few features of autoimmunity. And so a rheumatoid factor is a pretty useless screen if you're looking for arthritis, because you'll only find 10% of the patients with JA being positive. Just a quick word on antibodies. It's important to know which test you use. What we see here is immunofluorescence testing. A lot of people, 30% of healthy people, can have low slides. There's a different distribution. So the distribution of where the antibodies are binding in the DNA can tell you something. But what the key thing is that you need to understand when you're doing ANA testing is, are you doing an ANA which is a immunofluorescence-based ANA, which is a slow, laborious process where serum is labeled and then poured onto a nucleus, a tray full of cells with large nuclei, and then one can see if there's antibody binding to the nuclei, and then you can make out the pattern because of the immunofluorescence, and then that's diluted and diluted and diluted to see how dilute suspension still gives binding, meaning that the more you have to dilute it before it just, the stronger the binding, the more the autoantibodies are. So that's the ANA HEP2 testing, because the cells are called cervical cancer. The other testing that is available is ELISA testing, where you just test for specific ELISAs that you're looking for. So, for instance, you can have they're engineered antigens, and you can look for 8 or 10 antigens, or nowadays 12 or 15. But usually these are ones that are very disease specific, that tell you something about your patient with lupus, or about your patients that you suspect of having neonatal lupus with Rheumatology antibodies, or with imaging and X-rays. Just to say that X-rays are mostly there to exclude other causes for pain. This boy with a fracture of his wrist, and this one with fracture of his spine, which presented with spinal pain. The most important thing actually in early JIA or early connective tissue diseases that we see is soft tissue swelling, growth disturbance, joint space narrowing. Those are by far the most common thing that we see, and you have to be trained or at least aware to be able to look for those. Here's an example of soft tissue swelling around the ankle that you can see there, but also the overgrowth of the fibula, which tells you that there's been arthritis in that joint for a long time. We also can see periarticular osteopenia. Here you can see soft tissue swelling and periarticular osteopenia around all of the joints, and that tells you a lot about the fact that this child has arthritis. And you can also see a periosteal reaction here, which is a feature of psoriatic JIA. Erosions actually in pediatric rheumatology are relatively rare, but here is a pretty obvious erosion. And if you're at the stage where you're diagnosing arthritis by erosions, then you've actually missed the boat of diagnosing arthritis. This is where the juice money is. If you take a child like this and you look at the wrist and you wonder which wrist has arthritis, the one with the accelerated bone growth is the one likely to have arthritis, because arthritis accelerates bone growth and causes overgrowth. And in this child, it would be useful if you suspected the right wrist in this left on your screen of having arthritis to actually do that, to look for it. Ultrasound is extremely useful. Here's an ultrasound showing synovial hypertrophy around the joint, and that can be extremely useful. It can show you, and it can show you erosions. We get a minus sign where there's a clear break in the bone, like that. MRI with gadolinium can show you the synovitis. Of course, that's very sensitive in diagnosing things, and it can also diagnose difficult things that are difficult to diagnose in other ways, like bone edema, which is very, very useful, as you can see in this child with enthesitis-related arthritis and inflammation at his calcaneal. Enthesitis at the incision, and she mentioned that MRI is very useful. This is an example of the muscle edema that you can see on MRI. And other investigations. Carol mentioned systemic sclerosis in children. Here's a child that we looked after who had severe systemic sclerosis and a barium swallow with esophageal abnormalities, and also with quite profound interstitial lung disease on CT chest with honeycombing in the areas that I'm indicating there. Angiograms can be useful if you're looking for vascular disease. Here are the slides again of dermatomyositis. I'm not going to delay and go through these again. You've seen Carol had a beautiful set of slides on dermatomyositis, but you can see when you get calcinosis, which you can see on X-rays, you get muscle edema, and you get a typical heliotrope rash, which Carol so beautifully described. Then you can have dermatomyositis. But here's the key thing. Carol showed those periangular inflammations that are visible to the naked eye. But in most children who present early with JDM, these aren't visible to the naked eye. And a key investigation for anyone who's interested in making a diagnosis of JDM, especially if they're far away from an MRI machine, is to do capillaroscopy. Capillaroscopy is if you have a child with weakness, the typical skin features, and capillaroscopy like this, then you know you've got JDM. And I would argue that you really don't need to send this child to Johannesburg or to Bloemfontein or wherever to get a diagnosis of JDM made if you can do this capillaroscopy. And the nice thing is you can do this capillaroscopy yourself. And what you're looking for is these disordered vessels that you can see, vessels with major dilatation and infarcts, where you can also see areas where there are no vessels, where the vessels are completely infarcted. What you want to see, and there's unfortunately not one single normal vessel on this, is a vessel that goes all the way up to the nail and then turns and comes back in a nice little straight line. And you can see how that's not happening in this case. So this is how we do capillaroscopy. we just use an ophthalmoscope. You can do it with a specific tool like that, which is very useful, but we don't specifically have these headsets. So what we do is we take just a normal ophthalmoscope. We change it to 40 magnification just to get the magnification. Put a little bit of KY. Usually we use the second finger, and then we just for standardization. And then you just look at that area of the nail bed that you've seen is involved. And then if you want to be specific, you can sort of, with a capillaroscope, you can do a millimeter and then measure the number of capillaries that are abnormal or knocked out, and you can give a score and so on. But in most cases, you just really want to get a ballpark diagnosis. Is this dermatomyositis? Whether there's 7 or 8 capillaries knocked out is not going to make a difference to the child's care, I don't think. So yes, these are the features of dermatomyositis then, and I think what's key is just to think of juvenile dermatomyositis as a vasculitis, as these blood vessel issues in the fingernails show you. The gut, incidentally, will look exactly the same as the fingers if you do capillaroscopy on the gut. I wouldn't advise you to that. Diagnosis of JDM is then based on these skin changes, symmetrical proximal muscle weakness, elevation of muscle enzymes. CK is very sensitive in the early phase, but in children with long-standing disease, the CK can disappear. And don't forget that ALT, LDH are also extremely good muscle markers. So if you see a child with dermatomyositis or with weakness and liver problems, where just the ALT and LDH are up and not so much the obstructive enzymes, then consider that they might have a muscle issue rather than a liver issue that's causing them to be ill. MRI or ultrasound of muscle inflammation or a muscle biopsy. Muscle biopsies nowadays are exceedingly rare with all of the tools we've got to diagnose it, and I would only do it if the cutaneous features are not compatible with dermatomyositis. I just want to give a short reminder that dermatomyositis also can be incredibly destructive. There's a subtype of kids who get severe necrotizing pneumonia, so every child with dermatomyositis needs to have a baseline pulmonary screen and needs to be evaluated for that. Of course, this child would be, as you can see, very symptomatic, and in fact this child died. But we do regular DLCO screening and lung function screening on all children with juvenile dermatomyositis. The management Carol actually handled, and the most important thing to say about dermatomyositis is that corticosteroids should never be a standalone therapy. You must always start methotrexate at the same time as corticosteroids. You're never going to win if you start corticosteroids and then see if you can wean and then add a second agent once you can't wean. The evidence is very strong that you need to start the methotrexate off the bat, and if there's an issue with methotrexate, then cyclosporin, or if methotrexate proves not to work, then cyclosporin. IVIG can be effective, but of course very expensive. We give an infusion every month. Cyclophosphamide, especially for lung disease, and in some places where people get a lot of calcinosis. I know the Joburg rheumatologists see a lot of calcinosis. They use cyclophosphamide a lot. And rituximab and even TNF inhibitors can help manage, and nowadays the JAK inhibitors can manage JDM. I'm quickly going to move on to scleroderma. Carol has shown you this slide, and I'll just add my own photos. Just to make clear one thing that I don't think was explained, and this is the notion of Parry-Romberg syndrome. So if you have involvement of there's a syndrome, if you have linear scleroderma, which this is, and you can see the skin is involved and the skull is involved, the question, this is just termed linear scleroderma with uncroupta sabra, the cut of a saber across the face. If that involves the lower half of the face as well, and you get hemifacial atrophy, that condition is known as Parry-Romberg syndrome. And as Carol pointed out, this girl did, the one in the slide, this is not her MRI, but she actually has multiple lesions in her brain directly underlying the sclerodermatous lesion. This just shows another boy from our clinic with scleroderma, and I just wanted to point out the hypopigmentation, which can be profound. Also the change in hair color. You can see some of his eyelashes, well, you can't see, but I can remember that some of his eyelashes went white, some of his hair went white, as you can see on this slide as well. But actually this boy has had a tremendous outcome with just methotrexate as immunosuppression. Heat mapping of this can be done, but it's actually quite tricky, and these heat map cameras are not everywhere to be found. So we don't really use it in clinical practice, but a difficulty with scleroderma is trying to decide if the lesion's active, which is why that heat map might be useful, because a hot area might indicate active inflammation, might indicate the need to scale up your therapy. This just summarizes the localized forms again. And again, Carol had much better slides of the effects of Raynaud's on and the digital infarcts that people and children with Raynaud's get. What's interesting, what's key about diagnosing scleroderma, though, is to actually develop a bit of a habit when you're considering connective tissue diseases in children. Develop a bit of a habit for what is normal. What is normal skin in a child? When I say that, I mean how flexible is the skin, how loose is it, and how stiff is it? So almost every child that you examine, you should, with connective tissue in mind, just pinch the skin everywhere and get a sense for how soft and pinchable the skin is at the various age groups. The younger children have very soft and pliable skin, older people less so, especially in specific areas. But it kind of helps to develop your own sense of normal before you start trying to judge abnormal. Of course, there are cases where it's completely abnormal, such as in this case, with severe diffuse scleroderma, or what's called systemic sclerosis, where you can see she's lost her fingers. She's got incredibly tight skin around her mouth. She's got this micro mouth opening, and you can see even the lower half of her face looks small as the growth has been restricted by this profound scleroderma. Calcinosis, incidentally, can also be a feature of scleroderma. But you don't want to see scleroderma at that phase, like what we saw in that girl over there. You want to see scleroderma before that phase so you can start treating it. And how do you do that? A child who comes in with Raynaud's, not chilblains, a child who comes in with Raynaud's who has positive autoantibodies and who has capillaroscopy changes almost certainly will develop scleroderma. And we would actually either watch this child very closely or start methotrexate at this point already, because scleroderma creeps up so slowly, it's very difficult to get someone in a flare, as it were. These are all the features, using the Statue of David again, of systemic sclerosis, which I'm sure you're all familiar with. And just to show you, we've had one child with systemic sclerosis who developed all these digital, and who was HIV positive, but she developed almost the most severe scleroderma I've ever seen, with really terrible features with this lung disease. I think you've seen the CT before, but you can see that distal osteoacrolysis that's happened because of the loss of blood supply to the tips of the fingers. The fingertips are actually, bones are actually resorbing. It was also the same girl who had that esophageal problem. So this is one of the most common questions, or the most confusing areas of this whole field, is what's an overlap syndrome? Overlap syndromes are really where there are different terminologies that adults use, and they also use mixed connective tissue disease, etc. So mixed connective tissue disease is where you have features of either SLE and or JA and or JDM and or scleroderma all together. So not all of them together necessarily, but you have features of either one or both. So a common route that we see these kids do is either starting with JA, then going to JDM, then going to scleroderma, or starting with lupus and then going to scleroderma. So they sort of seem to progress and march and develop more of these diseases over time. And sometimes it evolves in front of your eyes. So it's worth remembering to look for the skin tightness, etc. Scleroderma is usually the last thing that these children get, my experience. I'm not sure if that's validated or anything. But these children can have high titer ANAs, speckled immunofluorescence on the HEP2 ANA, and they often are U1 RNP positive. So here's one of those cases where it's really helpful. If you think you might have a child with overlap syndrome, you send a ENA, the extractable nuclear antigens, and you get the U1 RNP. If that's positive, you know your child's at high risk for developing mixed connective tissue disease, and you might be more aggressive, and you might screen other organ systems more regularly to look for features. The other overlap syndrome is Sjogren's syndrome, which can be primary or secondary to any of the diseases we've mentioned. And it's just important to ask children about dry eyes and dry mouth. I think we don't do it very often. And the types of questions you ask about dry mouth, for instance, is can you speak for a long time without having to drink water? Can you eat supper without having to use water? Do you have to chew for a very long time because the food doesn't dissolve or doesn't get soft in your mouth? Those are the kinds of questions. It's difficult to ask someone, do you sometimes have a dry mouth? Who doesn't sometimes have a dry mouth? So you have to ask for these really functional questions. The same with dry eyes to an extent. Are your eyes always red? Do you always feel they're itchy and dusty? And when you wake up, are your eyes dry? And then anti-Rho and anti-Li antibodies, in this case, again, extractable nuclear antigens can be very useful to diagnose them. I just want to plug this app, which everyone should be able to download. It goes through the pediatric gait, arms, legs, and spine examination techniques, and is a very useful thing if you're considering musculoskeletal abnormality or pathology in children. And there's also this fantastic website called the Pediatric Musculoskeletal Matters website. It's a free online resource, and it'll be free forever because Prof. Alan Foster, who designed it, has made sure of that. It'll be free, and all you have to do is register as a healthcare professional, because there are children on videos and pictures and so on. And it's really a great source of information about the broad range of musculoskeletal and rheumatic diseases, so that if you face yourself with a patient and you're wondering and you can't get hold of a pediatric rheumatologist for whatever reason, then you can dip into this website and sort of go either through a systems or a problem-based analysis and try and get closer to an answer. So in conclusion, pediatric rheumatic or connective tissue diseases are all about pattern recognition, and it's not that complicated. Everything, the main things are really the diseases I've mentioned. I left out SLE. Sorry, Carol. I know you said I was going to talk about it, but SLE is really a whole talk on its own, and you did a great job of covering the clinical features. But a careful history and exam is key, and it's important to know why you're doing autoantibody testing. So with that, I'd like to stop. I haven't gone too long, and hopefully there's some time for questions. Thank you.